Thank you. Good afternoon, chairpersons, ladies and gentlemen. This is my first ISOT meeting like Dr. Kalra. So let's see how it goes. So I have been given the task of furthering recurrent infections and donor-derived infections. So the first thing that I'm going to take forward is what is causing these infections. And if you look at this diagram, this was made for the neurogenic bladder population and we published it in 2014. Oh, sorry. So, yeah, so I will further on what Dr. Kalra said. And if you look at this diagram, this was published in 2014, where we looked at what are the pillars which are causing infections. So the first pillar is that the pathogen has better access to the urinary tract, which could be because of alteration of the flora, or it could be going via a cath or whatever. So first is better access. The second is once it reaches, it sticks better. Now it sticks better because of a defective gag layer or whatever reason, the organism is able to stick. The third, after it sticks, the body's reaction is that it should get washed out with, with urination. So there are many reasons, inefficient voiding, hydrokinetic factors, that the washout is defective. And finally, relevant to transplant, that even if it has stuck and not getting washed out, the immune system comes into play. But in transplant patients, again, the immune deficiency may affect. So these are the four pillars on which you should be looking at when you're trying to treat your patients with infections. I'll just go through these four aspects. If we look at asymptomatic bacteriuria, it means that you're getting bacteria in the urine, but you have no symptoms. There are no local symptoms, there are no systemic symptoms. Pus cells wouldn't matter. It is the presence of 10 to the power 5 bacteria per high power field. Now, the question is this dangerous to the transplant patient, and should you be treating asymptomatic bacteriuria? There were two studies which showed that there is a possible benefit. Then there were two more studies, including an RCT, which showed that there is no difference. And then there were three studies which showed that there is an actual possible harm if you treat asymptomatic bacteriuria in kidney transplant patients. So what is the recommendation as stands? If your transplant patient is more than 2 months, do not treat asymptomatic bacteriuria. If less than 2 months, you will repeat the culture. If you get a different organism, or if the organism has cleared, do nothing. If you get multi-drug resistant organism, again do nothing. Well, if you culture and you get the same organism, whether to treat or not to treat is a personal choice. We don't. The only situation where you would probably want to treat is if you get unexplained rise of creatinine post-op, because uncommonly the asymptomatic pyelonephritis may be asymptomatic. So that's the only space where you may want to give the antibiotic. Infections in transplant patients, how common? So this is the most infectious complication in transplant patients, and 1 in 3 hospitalizations for sepsis is because of UTI. Now, for UTI, you need three things: pus cells, culture positive, and symptoms. Here, 10 to the power 5 does not matter. Even if you have a lower count, colony count, in the presence of symptoms, a 10 to the power 3 or 4 will also be considered significant when you are going to be diagnosing somebody with a UTI. Urinary symptoms, everybody is aware of. Dysuria is the central symptom, can have urgency, frequency, pain. Systemic symptoms, fever, chills, malaise, allograft pain, instability, leukocytosis, and if you get bacteremia with the same organism as in the urine. Now, sometimes you get, the only symptom is cloudy or malodorous urine. Is this to be considered a urinary symptom or no? Or will the person remain to be in the asymptomatic bacteriuria zone if he or she has only cloudy or malodorous urine? So the answer is the sensitivity of odor to pick bacteria or bacteria and pyuria is 50-50. So this cannot be considered as a symptom of UTI. So if your patient only has this complaint, he will still remain in the asymptomatic bacteriuria zone. How do you, and so now is UTI going to trouble the asymptomatic bacteria was not troubling? Is UTI going to trouble your graft? The answer is yes. And this is well known, and this will have to be treated. If only cystitis, early on you need to give drugs for a little longer period, so it's a 7 to 10 day period. Beyond the early transplant, 5 to 7 days is sufficient. If you get complicated, if you have systemic symptoms, then most people would treat it for 2 to 3 weeks. And in this setting of complicated, you would want a full urological evaluation and intervention as need be. As nephrologists, very severe infections, sometimes immunosuppression has to be looked into. Coming to recurrent infections, so what is a recurrent infection? If you're getting 2 or more UTIs in 6 months, or 3 or more episodes in 1 year, that is a recurrent infection. What are the recommendations for recurrent UTI? So there are 3 things that will need to be looked into and sorted for anybody who has recurrent UTI. The first is there a complicating factor that is causing the UTI? The second is the general things that sir mentioned, that what lifestyle modifications and what behavioral changes should be in place. And third is if you don't get any complicating factor, then what are the antibiotic and non-antibiotic antimicrobial things that you need to do in these patients. So we will look at these one by one. We'll take the B and C first. Lifestyle modifications. So fluid is important, and there has been an RCT which showed that people who drink more fluid pre-menopausal, there is a significant decrease in the mean number of cystitis episodes, and also a significant increase in the mean time interval between cystitis. So stay well hydrated. Other general measures: you shouldn't be holding urine for too long. Avoid after intercourse. Avoid sequential anal vaginal intercourse. Avoid spermicide use. And other general cleanliness measures that sir touched upon, which includes you take showers instead of bubble baths, wiping pattern wipe from front to back, tight clothing to be avoided, cotton to be encouraged, minimize douching spray powders in the genital area, and menstrual hygiene related to tampons and pads. So this is what is to be discussed with your transplant patients in order to prevent infections. A healthy gut is also extremely important. When we are treating children, we are more connected between the bowel and the bladder, but as we age, we forget that the gut microbiota is also a source of pathogenic bacteria in recurrent UTI. And you get these patients who say we were traveling and suddenly I had an infection, and that could possibly be because of the crosstalk between the bowel and the bladder, which we had published about 2 years back. So a healthy gut again is important. And finally, so these were things that the patient was supposed to do. What can you do? Avoid disruption of the normal vaginal flora. Do not give prolonged courses. Do not give broad spectrum antibiotics. Do not give unnecessary antibiotics. Control the sugars, and early removal of tubes after your catheters and your stents should go out as soon as feasible. Coming to non-antibiotic measures. So this was the general prevention. If you look at the non-antibiotic measures, Dr. Kalra has already spoken about vaginal estrogen therapy in peri-post-menopausal women, and this is practically recommended by all guidelines. So there is a new drug which is going to be launched soon, I believe, in India, which is methenamine hippurate. It's an old drug, but rebranded or refashioned. Now in 2020, there was a retrospective study which showed a decrease in UTI frequency as well as the hospitalization due to UTI. Again, 2022, a study with positive results. And then there was this RCT was in the non-transplant population, but they showed that the drug is not inferior to low-dose antibiotic prophylaxis in preventing recurrent UTI in women. So this is a recommendation now as well. Cranberry, the data is not too robust. The transplant guidelines do not recommend it, But this was in 2019, and after that in 2023 there is a Cochrane review which does talk about that it is beneficial. So cranberry is a little not that strong evidence, but can maybe considered. Lactobacillus we use in the regular population, but again the data for transplants is not really there. Now, if somebody is not getting okay with these non-antibiotic measures, what are the antibiotic measures that you can look at? So primary antimicrobial prophylaxis is something which many of us use, which is your trimethoprim and sulfamethoxazole for 6 months. And there is enough data to show that it decreases the risk of outpatient infections. If somebody is, so this was for 6 months, but if somebody is intolerant and you are going to give a different drug, the recommendation is that you shouldn't give nitrofurantoin or your alternate drug for more than, for beyond the first transplant month. So this was primary prophylaxis to prevent infections. Secondary means somebody who's getting infections, how do you deal with them? So the non-antibiotic strategies, which was vaginal estrogen, methenamine, all of those should be preferred. But the other two options are, if your patient is having a postcoital recurrent infection, then it's a low-dose antibiotic within 2 hours for 6 to 12 months. And for a certain subset, you may want to continue antibiotic prophylaxis for 6 to 12 months if that infection is not related to sexual intercourse. Coming to the A, so the B was the general stuff, the C was the non-antimicrobial and the antibiotic, and then coming to A, which means if somebody is having recurrent infections, is there a cause for that infection? So usually we would do an ultrasound, post-void residual urine and uroflowmetry to see if there is anything. Some patients would in addition require a invasive urodynamics or a VCUG. Complicating factors could be either in the native kidney or in the transplanted kidney. So essentially we're looking at either there is an obstruction, you have hydronephrosis, or if there is a VUJ stricture, so that's a structural abnormality. If that is not there, then we're looking at the bladder dynamics, and or if there is reflux, which is for what we do a video urodynamics or a urodynamics along with a VCUG. So I'll just share short 3 patients. So this was a 47-year-old perimenopausal lady, had 3 episodes of cystitis during the first year. First was soon after the transplant. She got a 10-day course of fluoroquinolone, became all right. Second episode at 6 months. At this time we evaluated her, and her ultrasound was normal, PVRE was negligible, uroflow was good, Qmax was 17. So at this time, again her UTI was treated with fluoroquinolone, but we started vaginal estrogen. In spite of the vaginal estrogen, again at 12 months, she had another episode at which time a urodynamics was done, which showed a high pressure, poor flow, and which essentially means an obstructed bladder, for which she underwent a BNI and has been doing well thereafter. This was another male having moderate obstructive symptoms but controlled with an alpha blocker, had a cystitis, and then the second cystitis at 14 months with systemic symptoms. So we evaluated. Post-void residual urine was 180 cc, pre-void was 400, poor flow, underwent a prostate procedure, again doing well. So if somebody is having recurrent infections, you need to see if there is something happening. When you do your evaluation and you get VUR is a little controversial. We all know that VUR leads to an increased risk of UTIs, that is undisputed. But do you want to institute preemptive strategies? Do you want to manage it preemptively? And what impact does the grade of reflux have on graft function? There is no consensus as of now. So most people would not post-transplant try to look for reflux. Only if somebody is getting recurrent infections would you go in and see. Doppler ultrasound is non-invasive to figure out. Gold standard would remain VCUG. If somebody remains more or less asymptomatic, you can wait and watch. Low to moderate reflux with symptoms, you could inject, which is an endoscopic procedure. Somebody having moderate to severe VUR and symptomatic, Again, if everything else is all right, you can think of reimplanting. But if age or other stuff are not in the right zone, then you could think of giving long-term antibiotics. So donor-derived infections. So these are infections which are present in the donor that is transmitted to one or more recipients. They could be expected, which means it's not a surprise, and then you give preemptive therapy or prophylaxis. Unexpected is when you, as far as you're concerned, the donor is not infected, but the disease shows up in one or more recipients. It is fairly uncommon, more common from the deceased organ donors. And if you get an atypical course post-transplant or an early infection, it could be donor-derived infection. So how do you mitigate the risk or decrease the risk for this transmission? So in this slide, if you see, if you're doing NAT testing for your HIV, HPSAG and HCV, if you look at HCV, if you're doing serology, it takes more than a month to up to 3 months for it to show up. Whereas if you were doing NAT, it would come up in 6 to 9 days. So this concept of what is the NAT window, which means after exposure, how many days will it take for your antigen test to become positive versus how many days will it take for your serology test to be positive, should be known. And then your history should tell you whether your patient is a high-risk candidate or a low-risk. And what would this mean? So there are guidelines where they've given a host of things: sex, paid sex with a man, sex with somebody who's known to have HIV, HPSAG. All of those, if you have a high-risk candidate who could be one of these, then so the screening that is advised is that for HCV, it should be NAT for everybody. The reason is, if you see here, the difference is 1 to 3 months versus 6 to 9 days, whereas in the other two, it's a little less. So for HCV, it should be NAT for everybody, and for high-risk HIV and for high-risk patients, then HIV and HPSAG should also be NAT. Testing should be done as soon as is practically possible, not later than 28 days. Now, I don't know what everybody is doing, but we are doing serology tests and we're accepting up to a 3-month report. But if we are to, but this is what the guidelines says if you are looking at picking up or avoiding donor-derived infections. Managing bacteremic donors, again, you look at the cost-benefit ratio, gram-positive, gram-negative, MDR, and you see how the patient has responded. So if the donor treatment with the targeted antimicrobial, there is a response, you have 24-48 hours where you assess that there is a response, then the transplant could go ahead with 1 to 2 weeks of therapy to the recipient against the organism documented in the donor. If you have a septic patient which is uncontrolled, then probably you will have to let it go. There are some places who send fluid culture, the transport medium fluid cultures for urine, for culture, and then give antibiotics accordingly if that is positive. So to conclude, UTI can have serious consequences. You should follow your patients closely, act judiciously, and when you have a problem, do act decisively. And let's hope all of you don't see this in your practice. Thank you.